Hello, I'm Ramzi Abboud, and I'm a leukemia and stem cell transplant physician at Washington University in St. Louis. I'll be speaking with you today about the role of itacitinib in the haplo-transplant setting, and more generally, JAK inhibitors in the transplant setting. Acute and chronic GvHD remain a barrier to allogeneic transplantation, a potentially curative intervention. These complications limit the use and safety of allotransplant. Acute GvHD occurs in 30 to 50% of patients who undergo transplantation, and chronic GvHD, depending on the transplant platform, between 20 and 50% of patients. Severe steroid refractory cases are associated with high mortality and morbidity. The last few years have brought a number of FDA approvals in this space, both for the treatment of acute and chronic GvHD. And more recently, abatacept was approved for the prevention of acute GvHD from unrelated donors. Importantly, this was before the widespread acceptance of post-transplant cyclophosphamide, and so it's unclear how translatable this will be to modern transplant platforms using post-transplant cyclophosphamide. So this is an exciting time for the treatment and prevention of GvHD. And we seem to be moving the field forward for our patients. There's a lot of justification for targeting the JAK-STAT pathway for treatment and prevention of GvHD. Ruxolitinib, a JAK1/2 specific inhibitor, is approved for the treatment of GvHD. Here at Washington University, we do a lot of research in T-cell biology and GvHD, and we've shown in preclinical models, in completely mismatched models, that JAK inhibitors can prevent and reduce GvHD with multiple different JAK inhibitors with different specificity, including ruxolitinib, baricitinib, and itacitinib. Importantly, these reductions in GvHD come without preventing engraftment, and also appear not to eliminate graft versus leukemia effect. There's justification for using a JAK1 specific inhibitor, such as itacitinib, which may prevent acute GvHD without impairing engraftment, and again, without impairing graft versus leukemia effect. We therefore performed a pilot study here at Washington University using itacitinib in a haplo-transplant setting with post-transplant cyclophosphamide. We enrolled 20 patients in an initial safety cohort, and then moved on to 20 more patients in an expansion cohort. We treated patients starting at day -3 from their haplotransplant, and continued the itacitinib in the pilot study through day 100, followed by a 30 to 60 day taper. This was all peripheral blood haplotransplants, not bone marrow. The primary endpoints were safety, specifically the rate of graft failure and the rate of acute severe grade 3 to 4 GvHD. And the reason we use those endpoints are, number one, JAK inhibition can cause cytopenias in other settings. And number two, we wanted to confirm that JAK inhibitors would not interfere with the post-transplant cytoxin effect and paradoxically increase GvHD. Secondary endpoints were efficacy endpoints, including the rate and severity of cytokine release syndrome and all grades of acute and chronic GvHD, non-relapse mortality, the rate of relapse, and then overall survival. The group of patients treated were expected patients undergoing allogeneic transplantation. Importantly, we only enrolled patients who are in a complete morphologic remission. We had no cases of primary graft failure, and both neutrophil and platelet engraftment were rapid. In fact, they were significantly faster than our historical haplo peripheral blood transplant controls here at Washington University. We had no cases of severe grade 3 to 4 acute GvHD and no cases of severe CRS. This is in contrast with our expected rates. Specifically of severe CRS, our expected rates are on the order of 17%, and we had no cases on the study. In terms of acute GvHD, Historically, we would have expected 12 to 14% of patients to have grade 3 to 4 acute GvHD with this transplant platform. And again, we had no cases in the first 20 patients. Overall survival and refined graft versus host disease and relapse-free survival were both encouraging at 82% at 1 year. We had 2 deaths on study, one from COVID-19 pneumonia and one from rhinovirus pneumonia. We had 1 case of relapse on study. The adverse events were those expected for a cohort of patients undergoing myeloablative allogeneic transplantation, and there were no specific treatment emergent adverse effects attributable to the study drug. And so based on this pilot study, we found that the intervention was safe and that the efficacy signals were encouraging. And so again, we are now enrolling on a 20-patient expansion cohort. We are about halfway through enrollment on that cohort. We have extended the dosing of itacitinib to 180 days prior to the taper, and that's because the drug was very well tolerated, and to separate the taper of calcineurin inhibitor from the taper of itacitinib. I'd also like to mention we are using a second JAK inhibitor, baricitinib, which has a slightly more broad profile in JAK and STAT inhibition. And we're testing that in the same platform in match unrelated donor and match sibling transplants, with results pending from that trial. So I think JAK inhibition is clearly a promising platform for prevention of acute and chronic GvHD after allogeneic transplantation. I think we know that this axis is important in the pathogenesis of GvHD, and so it's a rational target. It's also something that can be done in a economic and sort of real-world platform, much easier than some of the other graft manipulation techniques which have shown promise in other settings. And so, again, JAK inhibition for the prevention of acute GvHD is something we're excited about and we'll continue to study. Thank you very much.